Good evening and welcome to tonight's webinar. My name is Noluthando Nematswerani. On behalf of Discovery, in collaboration with SAMA, UFFP, and SAPPF, I'd like to welcome you to this evening's webinar. For those people who are joining us for the first time, we welcome you, but we know that there are those who have been participating in these webinars since the first series. We welcome you back. We did reinstate a new series of webinars during the second surge, and today's webinar will be the fifth of the new series. We do have a new custom where we honor and remember, the fallen clinicians who have succumbed to the virus. We would like to take a minute of silence to just honor them, and would like to send our deepest condolences to their families and friends. And we wish that their souls may rest in peace. So may we observe a moment of silence. Thank you, everyone. Tonight's webinar is CPD accredited. Certificates take about a week before they are ready. If you'd like to send any queries, please send them to cpd@discovery.co.za. All webinars are made available on the Discovery website under the tab for healthcare professionals. Please ask your questions on the Q&A button. Please don't use the chat button. Please do understand that we usually get a significant number of questions. We try and group them into themes and ask our panelists to cover as much as they can. Some of the questions we find that usually are covered during the presentation itself, but we would not want you to wait until the end. Please post your questions as soon as the webinar is open. In fact, when the speakers start talking. At the end of the webinar, we would like you to just give us some feedback. There will be a poll that will prompt you to give us some feedback. Please send us this feedback because it's very important in giving us a sense of what needs to be improved. Tonight's topic is really an interesting one: the impact of COVID-19 on maternal and reproductive health. I think we did hear some reports around, some impact in the second wave. So we've got a panel of obstetric and gynecology experts who I will introduce shortly, who will unpack this topic for us. We are very proud to associate with two of them who are Discovery Foundation alumni. We are actually welcoming them back into this series because they were here with us last year, and they shared their great insights. So we're looking forward to hearing from them again. The first speaker for the night is Professor Salome Maswime, who is an associate professor and head of the Global Surgery Division at the University of Cape Town. She is a World Economic Forum Young Scientist, Next Einstein Fellow, president of the South African Clinician Scientist Society. She's an obstetrician and a gynecologist, and she's the former Discovery Foundation MassGen Fellow, and she participated in this program at MassGen and Harvard Medical School. She's a trustee of the South African Health Systems Trust, and she's an associate editor of the South African Journal of Obstetrics and Gynecology, and a member of the UNITA's Global Surgery Foundation leadership team. She'll be followed by Professor Priya Soma-Pillay, who's the head of Department of Obstetrics and Gynae at the University of Pretoria, Steve Biko Academic Hospital, and UP Research Center for Maternal, Fetal, Newborn and Child Health Care. She's also the president of the College of Obstetricians and Gynecologists of South Africa and honorary secretary of the South African Society of Obstetricians and Gynecologists, and a member of the FIGO Executive Board. We would like to also welcome onto the panel Dr. Edward Dr Buga, who is a dual trained obstetrician and gynecologist and also an intensivist. He is a highly experienced clinician and spends his time oscillating between the intensive care unit and the maternity ward at Telemogwerane Regional Hospital. He's a basic assessment and support in intensive care instructor. He is the chair of the annual Africa Health Medical Obstetrics Conference and has certified training in critical care echocardiography, nephrology, and mechanical ventilation. He's a member of the South African Clinician Society, the South African Society for Obstetrics and Gynecology, the Critical Care Society of Southern Africa, the European Society of Intensive Care Medicine, and the European Society of Cardiology. As you can see, we've got an expert panel here who are going to then share some insights on this important topic of COVID in maternal health and in maternal and reproductive health. So I'm going to hand over to Prof. Maswime right now, and she is going to start with a presentation. And we will have a Q&A at the end.
Right. Thank you so much, Nolu. As always, really delighted to be here. It's always exciting to come. Also, as a Discovery alumni, it's also it's really what is really exciting to be part of this team. The three of us are going to talk about our experiences with COVID in pregnancy. I'm going to speak really from a global health perspective and talk about research and science in pregnancy during the pandemic. And I'm going to share some insights. Priya is going to go next and talk about what's been happening in South Africa, particularly with also women that did not have COVID. So the impact of the pandemic itself on obstetric and care and gynae care in South Africa. And then Edward is going to talk more about the management of the sick patient, the critically ill patient, and he's going to give us a few tips and pointers on how to manage very sick patients. So without me wasting much time, I'm going to start my talk. I hope you can all see it. So I'm going to start it off from a point. This is a quote that I got out of quite an interesting, from a journal that I was reading, that there are many unknowns for pregnant women during the coronavirus 2019 disease pandemic. And I think as I take you through my talk, you'll realize that a lot of research has been done, and over a short period of time, a lot has been learned, but still there's still a lot to uncover and understand. This is what I've called the evolution of research related to COVID-19 and the pandemic. And so at the beginning of the pandemic, the primary question was, is there mother-to-child transmission? And at this point, what we know is that it's plausible, but mechanisms are uncertain. And we moved from there to look at pregnancy outcomes in women with COVID-19 infection. What we know is that there's a risk of severe disease, maybe higher than in the general population. A question came up about breastfeeding and pregnancy, and we've learned since that infected mothers should be encouraged to breastfeed, but we encourage that they use PPE if possible at the time of breastfeeding. Then when we realized that even though the mother-to-child transmission was not really happening, but as healthcare workers, there is a risk of us getting COVID from our patients. There's a risk of patients infecting one another. And so that's when testing became an issue. So with research that has been done on that, we also realized that there are asymptomatic patients with COVID-19. It is common, but we're not sure of the clinical significance. Now, a theme that has come up that is quite important is mental health and pregnancy, because you've got women with increased anxiety and stress because of the pandemic, because of the fear of getting COVID itself, and because of the uncertainty during these times. And so this is work that is also being looked into. And most recently, it's the question about, should we vaccinate women that are pregnant, and what are the outcomes going to be, and what are the ethics of vaccination? But apart from that, a lot of the initial research was on COVID-19 and the pregnant women. But we started looking and thinking about what is happening to maternal mortality rates, what is happening to the pregnant population as a whole. And so the question on maternal mortality rates and stillbirth rates has become quite eminent. So besides the direct impacts of the disease, a plethora of indirect consequences of the pandemic adversely affect maternal health, including reduced access to reproductive health services, increased mental health strain, and increased socioeconomic deprivation. So whilst during this time and having a socioeconomic crisis, even pregnant women are vulnerable and could lose their jobs whilst they are waiting to have their babies. But an important question now is really what is happening to women who are not infected? And as I said, what the stillbirth rates, the maternal mortality rates, unwanted pregnancies, because women do not have the normal access to clinics as they did before. Contraception is not as easily accessible as it was before. But I'm not going to talk about this. Prof. Soma-Pillay is going to go a bit more into it. Vertical transmission. So one of the findings, you'll remember in my last talk, there was very little data on that, and we said that there was no vertical transmission. But since then, it has been found that in certain instances, there has been cases of vertical transmission. Initially, it was looking at the placenta and finding placental positivity, but that on its own does not indicate fetal infection. Having a positive PCR in a baby at birth also doesn't necessarily mean that the infection occurred in utero. But one of the advances has been with antibody testing, and that provided evidence that there is vertical transmission. It can occur, though it's very rare. And one of the things that proved this was the presence of IgM, which we know does not cross the placenta. Now, the issue is really the severity of disease in pregnancy. And in one of the CDC studies, which they found, they looked at close to 400,000 women, comparing pregnant women with COVID with non-pregnant women. They found that pregnant women were significantly more likely to require intensive care and mechanical ventilation than non-pregnant women of the same age. So this raises an alarm bell to us, because most pregnant women do fine, but some will get severe disease. And further to that, they realized that pregnant women faced a 70% increased chance of death when compared to the non-pregnant population. And that also, that was when pregnancy got looked at as a serious condition during COVID. Then if you look at a bit more on diversity issues, in the study, they found that Black women had experienced a disproportionately higher number of deaths. There haven't been many studies in Africa to report, but with the little that has been done from low and middle income countries, they did find in some places that there were excess deaths. But it's important to also caution that some of the deaths are due to their inability to access critical care. So it's also possibly due to health systems factors. As I mentioned, mental health of women who are pregnant is also a serious problem at this time, related to pregnancy during a pandemic as a whole. We all know that intimate partner violence has increased during this time. We know about the widening social inequalities due to the pandemic, and certain issues that I think we have a bit more control over as healthcare workers is trying to avoid the separation between mother and child, because there have been instances where in some nurseries where mothers have not been allowed, and we are discouraging that act. And then the separations of husbands and wives, or mothers and fathers, if you want to put it that way, and really looking at this and trying to be ethical in how these decisions are made. So I'm part of the International Network of Obstetrics Survey Systems, and what we do is obstetric surveillance research. And so in South Africa, what we formed was the South African Obstetric Surveillance System, which I'm part of. And one of the groundbreaking studies when it comes to COVID and the pandemic was the UCOS study, which many obstetricians will be familiar with. And there've been various studies that have been done by this group. It was the UK that we used the same model that the UK used for South Africa. We adapted that and other countries as well. So from the INOS studies, and this is not just UCOS, this is other countries that have already published some of their data. Their key findings were epidemiological studies on pregnancy and COVID-19 infection suggest that the pattern of disease severity in pregnant women is similar to that of the general population. These were early studies, and I think since then there's more and more data suggesting that severity might be higher in certain populations. To date, data did not show increased risk of miscarriage, early pregnancy loss, or teratogenicity. And I think that is quite similar across other studies that are being done in the world. Vertical transmission is considered probable. Causes of preterm birth have been reported, and then the risk of venous thromboembolism was shown to be increased in people with COVID-19, and pregnancy, as we know, is a hypercoagulable state. And this will be discussed a bit more in the last talk. So in South Africa, what did we find? Our study has been funded by the South African Medical Research Council, and the PIs for the study is Dr. Samantha Budram and Valerie Vanefel, as well as Dr. Laura Yates that we've been working with, and many other collaborators from various institutions. We've got 6 universities that are involved in the study across 6 provinces and 36 study sites. We closed the first set of data on the 30th of November, and that was looking at cases that occurred during the first wave. We are receiving more data for the second wave, and we are constantly happy to receive new sites, especially from private practice, because a lot of the sites are actually in public hospitals, so it would be great to have more of this. So this is our data, preliminary data. It's unpublished data, but we felt we had a responsibility to share a bit. So what we have found, quite consistent with a lot of what we found across the world, is that the majority of the women who were infected were in the 3rd trimester of pregnancy. Most women who had a comorbidity, it was HIV, not much higher than in the normal pregnant population, but hypertension seemed to be a bit higher than we expected. There was a higher rate of preterm birth and cesarean section delivery in our cohort. 1 in 6 women required ICU admission, and 1 in 16 women were maternal deaths. So as well, there is a serious concern about when the patients get really sick. When patients get sick, they can get very sick, even though the majority do well. So in summary of everything that I've said, most women will experience mild and asymptomatic disease. Some centers will experience increased rates of ICU admission and mechanical ventilation. There is a higher burden of adverse events in uninfected women. So we should never stop thinking about the women that don't have COVID, but think about all the women. And there is an increased need for mental health screening also amongst all the women. Thank you very much. I'll hand over to Prof. Soma-Pillay.
Thank you, Salome. I'll share my screen now. Good evening, everyone. Thank you for joining us, and thank you to Discovery Health for inviting me to speak. I'll be looking at the effect of COVID-19 on the use of maternal and reproductive health services and the effect on maternal deaths in South Africa. My talk will be divided into 2 parts. I'll first give a summary of our maternal mortality data up to and including 2019, and then the effect of COVID-19 on maternal death. So according to mortality estimates from UNICEF, approximately 2.8 pregnant women and newborns die every year from preventable complications. For mothers, complications leading to maternal death can occur without warning and at any time during pregnancy and childbirth. The National Committee for the Confidential Inquiry for Maternal Death was started in the late 1990s when maternal death became a notifiable condition. Maternal death is defined as a death of a woman while pregnant or within 42 days of ending a pregnancy, irrespective of site or duration. So since its inception, the NCCMD has documented a rise and fall in maternal death in South Africa, with an institutional maternal mortality ratio reaching a peak of 189 per 100,000 live births in 2009. This was at the height of our HIV/AIDS pandemic, and dropping below 100 in 2019. Furthermore, South Africa has committed to the World Health Organization's Sustainable Development Goals of reaching a target of less than 70 maternal deaths per 100,000 by 2030. So this graph summarizes our maternal mortality rates from 2005 to 2019, and you see that we reached a peak in 2009 at the height of our AIDS pandemic. This trajectory came down, or this curve came down very nicely, and in 2019 we were at the lowest and we reached a maternal mortality ratio of less than 100 per 100,000 live births. If we look at the provincial distribution and the average for South Africa for the last 3 years, we see that in 2017, South Africa had a maternal mortality ratio of 125, and this came down nicely to 98 in 2019, with an average of 113 for the triennium. Gauteng, 117 and down to 100 in 2019. KZN performed particularly well, 131, 99, and 82. In Mpumalanga, 148, 139, and 84. And the Western Cape has always outperformed the other provinces with an institutional maternal mortality ratio of 73 in 2017 and down to 50 in 2019. The top 4 causes of maternal deaths have remained constant for the last 2 decades. The leading cause of maternal death in South Africa is non-pregnancy related infections or deaths due to HIV and AIDS. And we see that since 2011, we've had about a 70% decrease in maternal deaths due to HIV and AIDS. Our second and third big causes of maternal deaths are deaths due to hypertension and obstetric hemorrhage, but also some decreases over the last 6 years. The fourth cause of maternal deaths are deaths due to medical and surgical conditions. This has remained fairly stable, and the leading cause of maternal death in this group is death due to cardiac disease in pregnancy. However, in 2019, we have observed an increase in suicide deaths in 2019. Number 5 is early pregnancy condition, and this consists of ectopic pregnancies and miscarriages. And this has come up for the first time, so we need to work on this. If we look at the age groups when our patients are most vulnerable, we see that at the extremes of age, most of our women succumbed during pregnancy, and this is particularly relevant for hypertensive diseases and the preeclampsia in the young preemie gravids, but also the older women. So this is the first part, and we've seen that South Africa has reduced the maternal mortality ratio. This has come down quite nicely over the last decade. But what has COVID caused? So I'll be looking at the effect of COVID-19 on the use of maternal and reproductive health services. And our data was published in December last year. And I'd like to acknowledge my co-authors, Professor Bob Pattinson, Sue Forkus, Professor Stefan Gebhard, Professor Jack Moodley, and Ms. Ronelle Nutt. In May 2020, Robertson and colleagues published a paper in the Lancet, and they warned of a potential increase in maternal deaths of between 8 and 38% in lower and middle income countries if routine and emergency services were not maintained by the health system or used by pregnant women. So we looked at the usage of maternal services and the impact of mortality for the first quarter, the first 3 months of the year, and we compared that to the second and third quarters for 2020. We obtained our data from the Department of Health Information Systems, which collects data on usage and outcome of various services on offer in the public sector. So we looked at the 2020 data and we used 2019 as a control. In the next few slides, you look at a few graphs, and there'll be a horizontal line, which is red, and that's the 0 line. So any value above the 0 line suggests more cases in 2020, and any value below the 0 line indicates less cases for 2020. So we looked at the number of births in facilities, initiation of antenatal care, contraceptive use, termination of pregnancy service, and the effect of this on maternal death. If you look at the first slides, and if you compare the first quarter of 2019 to 2020, And similar the second and third quarters, you see that we had an increase in live births in facilities in 2020 compared to 2019. The second graph looks at the difference, and the zero red line represents the zero line, so anything above indicates more births in 2020. However, we see that the increase was less in the second and the third quarter. This graph similarly shows that we've had more births in 2020, with a sharp dip in April at the start of the lockdown, and in July again at the height of our pandemic. This reflects the live births in facilities, in provinces and districts. And we see that an increase in live births in most provinces, but a significant increase in the provinces of Limpopo and Mpumalanga, circled in red. However, KZN in the second and third quarter had a decrease in births in facilities during the second and third quarter. And this is a similar picture is seen in the district, where there's a significant increase in the district of Ehlanzeni in Mpumalanga, but a decrease in live institutional births in Durban for the second and third quarter. If we look at antenatal care, the first visit before 20 weeks and the antenatal first visit in total, overall there's been an increase in antenatal first visits for 2020, but we see this sharp dip in April at the start of the lockdown, and again in July at the peak of the pandemic. Again, this shows us that more women attended antenatal clinics in the second and third quarter in the rural provinces of Limpopo and Mpumalanga, reduced visits in our metros and in the urban areas in Gauteng. So again, more visits in Ehlanzeni, but lower visits in the second and third quarter in Johannesburg, Tshwane, and Durban. If we look at the contraceptive use, the first graph looks at the different contraceptive methods, but overall we see that in January we started where there was an increase in contraceptive usage by our pregnant women, a sharp decline again at the start of the lockdown, and this continued for the second and third quarters where contraceptive use was reduced. Termination of pregnancy services. Again, the second graph looks at the average termination of pregnancy run over the pregnancy gestation, an increase in use of termination of pregnancy services for the first quarter of 2020, but a sharp dip in April again, and again this remained lower than 2019 for the second and third quarters. So what effect did this have on our maternal deaths? In 2019, for the first quarter between January and March, there was a total of 270 maternal deaths reported in South Africa. This came down to 235 for the first quarter in 2020. So this downward trend that we've been observing for the last decade continued for the first quarter of 2020, and we saw a 13% reduction in maternal deaths. Things changed, however, during COVID, and in the second and third quarters, we saw an increase in maternal deaths. 441 in 2019 for the second and third quarter, and this increased by 132 to 574. So we saw a 30% increase in maternal mortality in the second and third quarter of 2020 compared to 2019. This graph again, it's a graphical representation of our institutional maternal mortality rate. In January 2019, we started with an institutional maternal mortality ratio of about 120. This hovered around 100 for most of 2019 and the start of 2020. And then with the lockdown, our maternal deaths started increasing with the peak in June. This graph looks at our maternal mortality or excess maternal deaths in the general population. And we see that in the general population, the peak was actually in July. So for our pregnant women, the peak was a month before that of the general population. So we've observed a significant increase in maternal death after the lockdown and the surge of the pandemic. This has been associated with a decrease in usage of reproductive health services, our contraceptive and termination of pregnancy clinics, but a stable use of maternity services, but decreased use at certain period. We've observed an increase in births in public facilities, except for KZN, and this is possibly due to women choosing to deliver at home. We've seen a marked movement of women to rural areas, especially to Mpumalanga and Limpopo. So in conclusion, we've observed a 30% increase in maternal deaths, and this is most likely due to the indirect effects of COVID on maternal and reproductive services. There has been two markedly different effects of COVID-19 on maternal care. Our rural provinces experienced pressure on services due to women migrating from metropolitan areas back to their homes, and this placed an increased burden in already under-resourced facilities. The metros were inundated with severe COVID-19 specific conditions, resulting in difficulty in managing routine emergencies. So the recommendations from our paper is we recommend that basic maternal and reproductive services should remain open and functioning should a third wave occur in South Africa. There should be adequate means of transport to and between facilities for our pregnant women. Healthcare workers should be provided with adequate PPE and also emotional support. There should be adequate protection for pregnant women attending routine services. And we should ensure that pregnant women know that they should still attend antenatal care, contraceptive, and termination of pregnancy services. Thank you. I'd now like to hand over to Dr. Edward Buga.
Thank you, Priya. And then just good evening to our speakers, and to just thank Discovery for inviting me. So I will be talking about the critical care aspects of COVID-19 in pregnancy. Just like Prof. Maswime has actually highlighted, a vast majority of our pregnant patients experience mild disease, but there is a certain proportion of them that will experience severe disease. And this was actually first highlighted by the CDC in March last year, where they showed, and just like Prof. Maswime has shown, that compared to your non-pregnant patients, your pregnant patients who had a higher risk for invasive mechanical ventilation and ICU admission. And that same sentiment was shared by the United Kingdom Obstetric Surveillance study that showed that there was a 10% of their cohort of 427 patients required respiratory supports, even though they had a low mortality. And so there's been this whole question, how do we characterize, look at the risk factors and maternal and perinatal outcomes of patients with coronavirus disease in pregnancy? And what was then done is the pre-COVID living systematic review. And in this, they found out in a cohort of 77 studies, 11,000 women, 33% of those pregnant women had severe disease. 4% required ICU admission. That's 4% over 10,000 patient cohort. 3% required invasive mechanical ventilation. 0.4% of about 3,000 patients requiring ECMO with a low mortality. But then they noticed the risk factors for severe COVID. Most of the patients were in the third trimester. Those are high BMI. There was a medical comorbidity. And with your pregnancy and COVID, you had a higher risk of preterm birth rates, higher in ICU admission, even though there were low stillbirth and low neonatal death rates. And there was a follow-up of the United Kingdom Obstetric Surveillance studies. And one of the things that they highlight for it, it's still going to preprint, but was we didn't know about the asymptomatic carriers. Okay, your pregnant patients, COVID positive, asymptomatic. And what's actually been shown is even the asymptomatic patients have a high cesarean section rate. When they compared, they found 26% versus 32, a high NICU admission rate. So there is a significance for that. There was a high incidence of iatrogenic preterm births for mostly the symptomatic patients. And the reasons for the delivery was a deteriorating maternal status that was not improving, or for some fetal indications for delivery. And that then teased out the group of patients that we actually worried about when it came to severe disease. They had Black, African minority, and minority and other ethnic groups like Asian. They were overweight, pre-pregnancy comorbidity, chronic hypertension, renal disease, immunosuppression, maternal age more than 35, and then living in areas of socioeconomic deprivation. And that helps in your counseling, in talking to our patients. And these also, you look at, you can see that these are the patients that actually should be advocated to get the vaccine. So we do know they get severe disease. How do we tease it out? You should always have some form of severity scale to tease out the patients who are COVID. So I use a coloring system where I go from asymptomatic to very severe. So the asymptomatic patients, really no significance in them. We're not worried about them. The mild disease with fever, cough, myalgia, and anosmia also do quite well. But then when you start going down on the scale, the moderate disease, they've got pneumonia and imaging, abnormal blood gas, a temperature of about 39, despite them using antipyretics. Then the severe disease, and those are the ones that we really worry about. They have very high work of breathing. They're hypoxemic, their saturation is below 95. And then as you do further investigations, their PF ratio is less than 350% imaging, involvement on lung imaging. And then the ones with critical care disease or critical disease where they have multi-organ failure. We know COVID affects different organs in the body because of the distribution of your ACE inhibitors. So are they in multi-organ failure? Are they requiring some form of respiratory support? And then there's the new sort of outcome is refractory hypoxemia. And refractory hypoxemia is a failure in pregnancy to achieve a PaO2 above 70 on an FI, a fraction of inspired oxygen of 1%. And what do you need to do? And this refractory hypoxemia is then where you need to sit down with a multidisciplinary team, neonatologists, obstetricians, and decide the next phase, which we'll discuss in a couple of slides. The other thing that you can use to actually tell the severity is to use obstetric scoring systems as well, because they tell you about how the different organs in the body are affected by the COVID. You can have a bedside sort of assessment. Systolic blood pressure is low, very high work of breathing. They're not alert. They're not getting enough oxygen. This patient needs to be moved to the next level of care, high dependency unit or an ICU. And then if you've got your blood results and a whole of a panel that you look at, you can look at how it affects your respiration, looking at your PF ratio, your platelets. The more severe it is, the lower your platelets, the higher your bilirubin is. So you have a scoring system and a scale that tells you about the severity of the disease. Other way of picking out the severity is also with the oxygen support that you give them. In mild disease, if you're giving 15 liters of oxygen, you will find as you increase your fraction of inspired oxygen here, if you look at the blue line there, your PaO2s improve. You know, your target in pregnancy should be a PaO2 of 70. So in mild disease, as you increase the FiO2, you see the PaO2 is high. You don't aim for that very high PaO2s, but it's going to about 70, that's where you want. Severe disease is the one you'd worry about. As you increase the fraction of inspired oxygen, you're not improving your PaO2. That is when you decide this patient needs a higher level of care. Can I then move them to a high dependency unit? Can I move them to an ICU? Who can I call? So you have a care pathway that you need to always have. You know they get severe disease, you tease out the ones with severe disease, and then you hand them over to the team that can look at them. And the next thing is to also consider and remember the fact that if you're going to be managing these patients, you also have to remember the fetus. So remember the blood flow to the fetal placenta unit is affected by hypoxemia. And a lot of these patients present in the ARDS. Alkalosis, if the mother has a low blood pressure, if you're on some form of vasoactive medications that are indicated, you should also remember that they reduce uterine blood flow. So you can improve oxygen delivery for the mother by optimizing maternal arterial oxygen content, improve her saturation, make sure she's got a hemoglobin that's about 8, and then you improve her cardiac output. And then in your ventilation as well, always to remember in pregnancy, we tend to aim for a lower CO2 target, 28 to 32. But because you might be ventilating this patient, just remember maternal hypoxemia decreases uterine blood flow. There might be instances where the patient has a high work of breathing and their CO2 is very low. Be careful about that because the harder they work and the lower the CO2, it's also going to decrease uterine blood flow. And then mild hypoxemia increases uterine blood flow, but anything above 60 is detrimental to fetal outcomes. So you'd always commence your oxygen therapy for maternal saturation less than 94, and aiming for a PO2 of 70 and a saturation about 94 when they're pregnant. And when you're looking at your therapies, you have supportive, immunomodulatory, and antiviral. But antiviral, predominantly, we don't have anything that's acknowledged by our regulatory bodies. But you look at your conventional methods of oxygen delivery. So you have a continuum coming from for acute hypoxemic respiratory failure, nasal cannula oxygen, simple face mask. Then you have the reusable face mask oxygen. What you're trying to do is improve the patient's saturation. And the fraction of inspired oxygen that they give is on a continuum from 24 in the nasal cannula to about 90 in the reusable bag mask. They're available, simple to use. The thing about them is they cause dryness of the upper airway. And also, the fraction of inspired oxygen is actually not as accurate if the patient's work of breathing is higher. Then when you move on to nasal high flow and CPAP, the thing about them is they give a much stable FiO2. They are aerosol generating, but we do use PPE and we know about them. And then rarely do we get patients who present with hypercapnic respiratory failure, but when they do, we can always put them on non-invasive ventilation. Okay, so one of the things that we use is high flow nasal cannula oxygenation. And the very nice thing about high flow nasal cannula, it's non-invasive, it can be used in a high dependency unit, it helps you avoid intubation in the patients that you tease out. And the thing about most therapies, you start them, you look and monitor to see that they're working, and you go on for that. So you have increased mucociliary clearance, and it's been shown that a certain percentage of your COVID patients have mucus plugs. So this improves, they have a dead space washout, and these two wanted to show that then your work of breathing is just predominantly towards oxygenation. There's an improvement in pulmonary mechanics. And one of the nice things about high flow is you're giving the lungs of the patient the oxygen at a rate that they require it. So one of the things that happens is you reduce the work of breathing. There is a positive pressure that is also generated. So it improves end-expiratory lung volumes, improves your lung gas exchange. So now you need to know that it's working. The thing that we look at is called the ROX index, and it's here to the right. The ROX index looks at your SPF ratio, but your denominator is your respiratory rate. As your respiratory rate decreases, it actually shows that this modality is working. Your ROX index is about 4.88. You do not need to intubate your patient. But if after 2 hours, 6 hours, and 12, as you monitor, the patient's respiratory rate is not improving, it actually means they are not coping on that modality. You need to consider either transferring them to a center that requires it or move to the next form of therapy, which would be to intubate. Then there is the non-invasive positive pressure ventilation. And one of the advantages with this is you can monitor. It gives a PEEP, which helps with keeping your lung units open, and it also gives a support and helps with you reducing your work of breathing. And even though a lot of guidelines don't really recommend it in pandemic viruses, but if you have it in your center, you can use it and monitor the patients quite closely. It's predominantly used for acute cardiogenic pulmonary edema. There will be cardiac manifestations of COVID. Those are known, and you can use it for that. But if you have a patient on NIV that has got COVID, you need to monitor them very closely. And what you want to do is that they're getting enough oxygen. Their work of breathing, their respiratory rate is improving from the time that you actually started it. And that's why you look at what you call a HACO score. The HACO score is actually available as an app on a lot of phones. But what you're looking at is the higher the heart rate, the higher the score. So a score above 5 means this modality is going to fail. You would see the heart rate is improving if the patient actually should stay on it. The GCS improves, or it may worsen. The PF ratio as well, if you've got a blood gas machine available, and the respiratory rate. That's actually very important. Your respiratory rate, your PaO2, what is the patient's work of breathing? If it's not improving on this modality, it means they need to move on to the next one. And then also when you use CPAP, we have a lot of CPAP that's actually come up, and most of the one we have is the wall CPAP. And the thing about it is also in high incidences of pandemic surge, also can be used for hypoxemic hypoxic respiratory failure. But also to remember, the sicker the patient, the higher the risk of failure. So as you can see here, if you have high C-reactive proteins and D dimers, those are markers of a high inflammatory state. If your PF ratio is very low, that's below 70 to 80, more severe type of lung injury, the work of breathing is very high. I'm highlighting the orange side. Or there's affectation of your heart, your NT-proBNP and troponin are high, your CPAP is going to fail. So that helps you tease out the patients who are actually going to fail on this modality. and then you move on to intubation. It's been shown that patients on non-invasive forms of oxygenation or ventilation, the mortality is higher the longer you delay to intubate them. So if you have some sort of algorithm that tells you they're not coping and you move to the next one and get to intubate, you do two things. You help tease out the ones that actually need to be intubated, and you actually then intubate them much earlier than later, which is actually detrimental. And then there's proning. Proning, it's something that has actually been discussed. You can awake prone. The patient, it's easy to do up to 34 weeks. You can use pillows like it's shown here, or you can actually have patients who are mechanically ventilated and have got neuromuscular blockers who are prone. And what proning does in essence is, if you look at this on the left, that's supine, on the right is prone. And look at the lung units at the bottom here. You see the lung units in the ventral surface in the supine region are actually open. They've got air in them. When you turn them into a prone position, you increase the number of lung units that are actually, we call that a recruitment. So the first thing that proning does, it recruits your lung tissue. So you have more homogeneity. It improves your oxygenation. It improves your shunt fraction. The other thing it also does is it unloads the right side of the heart, which is actually a very good thing to do. Then the last thing on the scale will always be mechanical ventilation, and the universal principles apply in the pregnant and the non-pregnant population. You have a tidal volume limitation. And the thing about mechanical ventilation is you need to decide what lungs you are ventilating. There's been talk about the phenotype L and the phenotype H in COVID pneumonia, and it's up to the clinician to pick that up, because you then tailor your ventilatory strategy for the individual patient. And the universal principles, you have a plateau pressure less than 30, driving pressure less than 15, you have a PEEP to the best compliance, and then your adjuncts to ventilation, neuromuscular blockade, front position like we've shown, and to use ECMO if you have it available in your center. And they always say ECMO should only be in specialized centers that actually do have it. And then a conservative fluid strategy guided by hemodynamic endpoints. And then there's a new thing that has also brought in the ethical question, algorithm for refractory hypoxemia. What do you do with the patient who's COVID positive, pregnant, mechanically ventilated? You are on what the guidelines say, prone positioning, appropriate PEEP, neuromuscular blockade, but you're not getting to your PA2 is above 70, your PF ratio is less than 150. That patient is with refractory hypoxemia. You could try inhaled pulmonary vasodilators. They give you a very short period of leeway for 24 to 96 hours. If there is slight improvement, you can go with expectant management to recovery. But if there isn't, and then more than 32 weeks of gestation, you then have to do a multidisciplinary team and say, we're not getting to our oxygenation targets. Like I'd mentioned, hypoxemia reduces your oxygenation of your fetal placenta unit. You might have to consider delivery. And if it's available, move on to ECMO. And that's the new thing that you should actually think about. And there's been shown a lot of data showing that preterm birth rates have actually increased with COVID. And one of them is a deteriorating maternal status, and something to discuss. And then anticoagulation for COVID. Yes, we should be giving prophylactic anticoagulation for inpatient pregnant patients with COVID, unless birth is expected in 12 hours. When they're discharged, you should give them anticoagulation for 10 days. There's persistent morbidity, you can give it for longer. Postpartum, you give it for up to 6 weeks. And then therapeutic anticoagulation for confirmed or suspected VTE events. So we don't just give therapeutic anticoagulation. And when you give therapeutic anticoagulation, you aim for we use low molecular weight heparins. You're aiming for antifactor 10 levels of between 0.8 to 1.2. And then watch the platelet levels, because if they stop, they're low, you have to stop your aspirin and the thromboprophylaxis and use mechanical aids. In treatments, dexamethasone has been shown to work, so we use steroids. And then the recovery protocol for pregnancy is 40 milligrams of prednisone or 80 milligrams BD per ounce. And if the patient can't take them per ounce, you go with your Sodicort, if you hydrocortisone, 80 milligrams BD. And then your interleukin receptor antagonist, tocilizumab, you can use it. If you look at the United Kingdom Teratology Information Service, they say it's a safe drug in pregnancy. But in SA, we've got when to say you shouldn't be using it outside of a clinical trial. Remdesivir was one of the drugs that was touted, but as a part of our regulation in South Africa, we don't actually use it outside a clinical trial. And then it's those are the kind of treatments that you would have. Vaccination. Now, we've seen that pregnant patients are the group of patients that are at risk for severe disease, okay? And because they're at risk for severe disease, especially in the third trimester, we then make an argument that we should actually have pregnant patients vaccinated. Unfortunately, the initial trials didn't actually involve pregnant patients, but we do. If you look at the risk profile, health workers who are at the forefront in a pandemic, they're going to be exposed to a lot of patients, or essential workers, patients who have some form of medical comorbidity, a weakened immune system, the ones who are obese, who are smokers, those are the patients that we should actually be having a discussion with and having a counseling session on whether or not they should actually have a COVID vaccine, and I believe that they should. And then quickly with postpartum considerations, you monitor your input and output to prevent hypovolemia, you encourage breastfeeding, but of course in an ICU setting that won't happen, but in the other wards and when you're down for taking the patients out, you can do that. And post-operative contraception, you avoid COCs for the first 6 weeks, then you screen for postpartum depression and anxiety. So in summary, pregnant patients are included in the list of individuals who are at risk for severe COVID. You have your early oxygen therapy aiming for SATs of more than 94. You have high flow nasal cannula and proning of benefit. Data supports CPAP and IPBV use with very close monitoring of those endpoints. Consider delivery for refractory hypoxemia at 32 weeks and to offer vaccination to pregnant patients, or at least the very high risk patients, like I mentioned in the slides. Thank you.
Thank you so much. Thank you to all our presenters, Prof. Salume, Dr. Buga, Prof. Priya, Soma-Pillay. Thank you so much. I think a lot of questions were coming through around the vaccine. So Dr. Buga, your last few slides were very important in addressing most of the questions that came out from the Q&A. I think what maybe we can do is to just maybe wrap it up on the vaccine around the fact that there's a question that's asking if a healthcare worker entering their third trimester of pregnancy should avoid exposure to COVID patients in a GP setting. That's one. And the risk of, teratogenicity in women who have taken the vaccine.
Yeah, so one of the things, excuse me?
Now I'm saying let's stick with those two questions.
Okay, great. So one of the things is ideally, because pregnant patients, as you've shown, the risk for them for getting severe disease is high. Before they get to the third trimester, they should actually get the vaccine. The other thing as well is for pregnant patients, because we know they're at risk for severe disease, some form of occupational health and safety risk scoring needs to be done, okay? So what is the risk? Now, this person is in a busy GP practice. She's actually exposed to patients in a pandemic who are actually potentially going to infect her. That she should actually, she should get the vaccine. That's what I would say. The other thing is, can you actually give them time off? Because in some settings, if you sit with the occupational health and safety doctor and they're pregnant, we do actually give them off from 28 weeks. That's what we've been doing. And that's something that they should consider, because you need to show that in the environment that they're working, the risk is not higher than outside where they live. So this person is actually at a high risk. She should get the vaccine before she gets into the third trimester. Now, the thing about toxicity, they didn't do the studies on pregnant patients, unfortunately, but they did it on pregnant mice. So there's what they call developmental and reproductive toxicity studies that were done. And in those pregnant mice, they actually showed the doses that were used did not cause any teratogenicity. While we await the outcomes of more than 30,000 pregnant patients who were health workers who volunteered to actually take the vaccine. So I hope that actually answers the question.
Thanks so much. And then there is a question around maternal hypoxemia and the impact in terms of fetal brain development. So the question is around oxygen deprivation, possibly leading to that problem in the baby. So your thoughts there?
Maternal hypoxemia has been shown to reduce blood flow to the fetal placental unit. if you have a reduction in fetal placental blood flow, you would have a reduction in the oxygenation that gets to the placenta that's going to be transferred to the baby. Okay, so baby will go through acute hypoxemia, and then depending on its what do they call it, its ability to withstand that, it actually does have a detrimental effect. And that's why on the slide where I spoke about refractory hypoxemia, it's like if you're getting on whatever modality that you're using, you are not getting to the endpoints that you need. You then need to discuss with a multidisciplinary team and decide on delivering the baby at that time. But it has to be a decision that everybody makes. And also the hypoxemia will change the fetal behavioral state. So the long-term outcomes are actually very poor. Priya is a fetal medicine specialist. She can highlight more on that, but that's what I would say.
Thanks, Dr. Buga.
Maybe just to add as well that in such severe maternal disease, our guiding principle is that the mother always comes first. So we look at the maternal condition and try and save her life. And unfortunately, the fetus will come second, but there is a detrimental effect. So we'll do whatever we can do to save the mother.
Thank you so much. Actually, Prof, you can just stay there because there's an interesting, I'd rather say it's a comment rather than a question around some data from a private practice, looking at a cohort of 30,000 odd deliveries that they saw a prevalence of COVID positive patients of 4.93%, but they saw a mortality rate that was increased by 3 times, which means they saw a substantially higher mortality rate than the public sector. I'm hoping that that's what this post means. So they're saying this is surprising for me, and the only reason for that could perhaps be that out of hospital deaths for public sector may be significantly more. So that's a part of the excessive deaths, which does not reflect, maybe, I'm sure it was meant to say private sector numbers, but it says public sector numbers. So I'm assuming that that's how it should read. But what do you think of this? Just a comment on this particular post.
So prior to COVID, the private sector institutional maternal mortality rate has always been lower than the public sector, although the causes of maternal death have been consistent with the public sector. So hemorrhage and hypertension and medical and surgical conditions are also a problem in private sector, but the institutional maternal mortality rate has been lower. So a 3 times increase is probably reflective of the lower baseline that we're coming from. But also, as I've indicated, is that we looked only at institutional maternal mortality rates. And we believe that in certain provinces, particularly in KZN, women chose not to go to the hospital and chose to deliver at home. So it is possible that we've missed some of the maternal deaths in our report. But this is the data that we have from the DHIS, and this is only institutional. So there's a good possibility that we've missed some of the home deaths. I agree.
Okay, thank you so much, Prof. Maswime. Maybe let me bring you in here around people trying to conceive. Is it safe to be doing your IVF and getting vaccinated? And I think there's another question that spoke about just trying to conceive, not necessarily, with artificial, types. So can we maybe get your input on this one?
Yeah, thank you very much. And I think the question was really saying that should we be advising women not to fall pregnant during this time? And I think it's more of an ethical question. It's a health systems question as well, that you can't really stop women from falling pregnant. In fact, the unmet need for contraception is much higher during COVID, because as you saw in Professor Soma-Pillay's talk, that women have not been accessing contraception as they should. So I think the measures should be more to educate women on accessing the services that they need, finding ways of strengthening their healthcare system, because we know that we'll not be able to if we try to do it that way, that won't work. But I think it's more of a challenge to those that are working in health systems and managers to say, how can we ensure that women are getting adequate messages? policymakers, those who are speaking to women, who are speaking to the general public about COVID on a regular basis, to make sure that there's messaging for pregnant women as well about reproductive health care.
Are you expecting a baby boom in 2021 following the lockdown? Yes.
Sorry, I would also just like to add that if women are planning a pregnancy, they should preferably take the vaccine prior to getting pregnant. And hopefully that will protect them during pregnancy.
So I think there's a question linked to that in terms of medical legal implications if there is teratogenicity that is picked up in the long term. What are the medical legal implications? Because we know that we don't have long-term safety data in pregnancy. So what?
I think the basic understanding, as Dr. Buga already alluded to, that we all know that the vaccine could not be tested on human pregnant women, that it was tested on rats, and we're using that data, so even when you take the vaccine, it's consenting to the fact that that there aren't enough studies that are going to, there isn't enough data for that. And so it's really ends up becoming you take it with the understanding that this is the situation, but we are in a pandemic. We understand the benefits of the vaccine. We recommend the vaccine, but also knowing that, we really don't know what the long-term data is going to be on this.
And then the impact of a cesarean section on a COVID positive mother. Does that not add a significant burden? This is the question here. Cesarean section, COVID positive.
That's a very good question. There is the recognized burden of just a general cesarean section on all patients. You will have the risks which either due to bleeding, and Prof. Salome would know a lot about that. There's infections, but those rates have always been low. It's just that the more severely ill the patients are, and you have to make a delivery for either maternal or fetal indication, a cesarean section actually is in a more controlled environment. And what that means is, if you're going to do it in a more controlled environment, it's elective procedure done with the most specialized team that's available. And generally, what should actually happen is, you look at the patient, you look at what amount of support that they're on, how much of ventilation, their fraction of inspired oxygen, what organs are affected or not, and then you decide on that path to go. So on its own, it shouldn't, okay? And you get the best surgeon to actually do it. You want to ameliorate worsening the condition. Now, the Society of Maternal Fetal Medicine has shown something else. There is also the mechanical effect of the pregnant uterus as well on ventilation or your lung mechanics as well. Your lung volumes are reduced already, your end expiratory lung volumes. Now, add the fact that this person has got inflamed edematous lungs, and the extent of it is very high, so that mechanical aspect. So there is a theoretical benefit as well, okay, of doing it, but it has to be done in a very specialized center and the most skilled people to do it. So that's where I'd come from a standpoint. So it's not something that we just decide. Your anesthetist needs to agree, the neonatologist, the maternal fetal medicine specialist need to, and then we all look at the best forms of care, and you'd find the most severe, the ill the patients are, cesarean section for the indication would probably be the way to go.
Thanks, Dr. Buga. Last question, because I see people are starting to leave. I think this is just a practical question saying, how do we manage a low-risk COVID positive pregnant woman who is in labor? Do we admit and deliver them in a general ward room or in general isolation? So that's...
Any of us.
Anyone.
Well, the low-risk patient should be delivered. But the thing about it is there's always been this question on whether labor is an aerosolizing procedure, okay? That deep exhalation process that occurs at the time that they're in the second stage is actually, some consider it an aerosol generating procedure, which means the risk of infection to the health workers is actually quite high. So they shouldn't be in the general ward. Okay. They should actually be in at least a good enough isolation or a cubicle of their own. and the health workers that are affecting the delivery need to actually be in appropriate PPE. And that PPE is for an aerosol generating procedure: the gown, the cap, the visor, the N95 mask, the boots, and the gloves. That's the way to go. Even though there's still a debate on whether it's an aerosolizing procedure, it's the way to go.
Thank you so much. Thank you so much, Professor Dume Maswime, Professor Priya Soma-Pillay, Dr. Edward Buga. It's always nice to get insights from experts, and I think it was also very nice to see our own local data being shared tonight. So thank you so much, and thanks to our participants who joined us tonight. And thank you so much. Have an awesome evening. Good night.